Hi, Dr. Tanner. I was hoping to review a patient with you. Mrs. S is a new patient to me. She's a 53-year-old female Caucasian, otherwise healthy, who presents to the clinic for a second follow-up scheduled visit due to a history of a 12-week persistent chronic cough, a 6-week sore throat, and a 4-week hoarseness of voice. Her initial clinic visit 8 weeks prior to today's clinic visit, client's cough was assessed to be clinically associated with gastroesophageal reflux disease with a prescribed 8-week trial of pantoprazole and trial of reduced acid reflux diet with no resolution of cough. Today she presents with tumor symptoms of sore throat and hoarseness of voice. There was no acute onset of illness prior to the dry cough starting. She is into her pharynx and inferior to the pharynx. Her symptoms last all day, worsen at night, a 5 out of 10. Slightly better during the day after clearing excessive nasal secretions. They're about a 3 out of 10. Mrs. S feels that there's draining at the back of her throat, and she felt resolution months after on vacation for a week in Vancouver. But then once home, her symptoms returned. At her first clinic visit, her coughing seemed to be worse after supper and while sleeping. She felt like something was stuck in the back of her throat, but now it's all the time. Mrs. S reports that she has never felt these symptoms prior. There are 2 new puppies in the home for the last 3 to 4 months. She's been afebrile, no close contacts, similar symptoms, no seasonal allergies, no travel outside of Canada. Client reports that she is fatigued because she hasn't slept through a night over the last 12 weeks. There's no rashes to her skin, no visual changes, no headaches, no ear pressure or pain. The client is experiencing hoarseness to her voice, though. Client has had excessive clear nasal secretions, worse at night, and constant sore throat. She denies seasonal allergies or annual seasonal symptoms, no previous acute illnesses prior to the cough starting, no tightness to her chest, no night sweats, no dyspnea or loss of taste. She denies choking episodes prior to her cough or over the last 12 weeks, and she had gnawing abdominal, she had no gnawing abdominal or epigastric pain at all. No episodes of regurgitation with burning pain to her esophagus, and she denies nausea and vomiting. No changes to the dietary intake other than reduced acid reflux diet since her last clinic visit. Mrs. S has no changes to her weight. She denies hemoptysis, no orthopnea, upright or laying down, no chest pain or discomfort. She currently is taking the pantoprazole 40 milligrams orally once daily, and she does complete her prescription in the next 2 days, and she has had 100% compliance with it. She denies any over-the-counter medications or herbal supplements. She does have known allergies to cat dander causing rhinitis, ocular pruritus, mild wheezing, dyspnea, sternutation, urticaria, and penicillin causing urticaria and pruritus. Both allergies were confirmed by intradermal skin testing by an allergist when she was a child. Her past medical history reports currently healthy, really. No chronic health diagnoses, and her immunizations are up to date, including her DTaP and 5 COVID vaccines. She has no personal or family history of tuberculosis. There was exercise-induced asthma when she was a child. She denies any asthma attacks since her early adolescence, and they were managed with Ventolin. She had a tonsillectomy at the age of 8 without any complications. Her social history includes 1 glass of wine a week. She's a lifelong non-smoker, denies any secondhand smoke or exposure to any toxins. She denies any illicit drug use, including marijuana, and she's been married for 27 years with a 16-year-old daughter, and she works as an accountant full-time out of her home. On her physical exam, Mrs. S independently was mobile with no dyspnea. She appeared her stated age, and she did definitely appear fatigued. She was groomed and dressed appropriately, and in no distress. So she communicates an accurate recall of events and background history. She's a reliable historian. Her vital signs were 36.6, her her temperature was 36.6 degrees Celsius. Her blood pressure was 118 on 72. Her heart rate was 74 beats per minute. Her respirations were 18 breaths per minute. Her oxygen saturation was 98% on room air. Her GCS was 15 and her BMI was 23. Her chest wall was symmetrical, atraumatic in appearance, no dyspnea, no productive cough. There was a non-productive cough that was present. Her respirations were easy and regular. On palpations, there was no tenderness or pain or lesions. Posterior and anterior extension was symmetrical. Her lungs were resonant with her breath sounds being vesicular. No wheezing or advantageous breath sounds were heard. Tactile fremitus was symmetrical with no dullness noted. No tenderness or pressure or pain to her frontal maxillary sinus cavities. Her trachea was midline. Her thyroid was palpable and not enlarged. She did have submandibular and anterior cervical lymph node enlargement. They were about 1 centimeter by 1 centimeter, all mobile and non-tender. She had slight bilateral redness and irritation to her sclera that was noted. No conjunctivitis, discharge, or blepharitis. She did have clear epiphora bilaterally. No enlargement to her lacrimal glands. External auditory canals were intact with no arrhythmia. Tympanic membrane was intact with good contour and color. She had red and scaly dry contact dermatitis to the tip anterior and bilaterally of her nose. Her nasal septum was midline with a small polyp to the right medial nair. Thick, viscous, clear nasal discharge was present. Partial bilateral nasal congestion was also present. Nasal mucosa was reddened. Posterior pharyngeal wall, it had a cobblestone erythematous appearance with bilateral pharyngitis. Clear, thick, viscous pharyngeal nasal drip was present. Her tongue was thick and moist, no candidas, abscesses, or purulent exudate. And her voice was definitely hoarse. On her cardiovascular and peripheral assessment, her JP was plus 2 centimeters above sternal angle with the head of her bed at 30 degrees. Her carotid pulses were plus 2 amplitude, brisk, and they were brisk and smooth. No thrills present, S1 preceded S2, and no bruits. No peripheral or pedal edema was present. Her abdomen, she had normal active bowel sounds ×4. Her abdomen was soft, not tender in all quadrants, and her abdomen was not distended or pulsating, and no masses or hernias were palpated. A diagnosis of upper airway cough due to postnasal drip and rhinitis is what I do think is going on clinically. Likely caused by exposure to a new allergen, and I'm questioning dogs. One key feature was leaving the home for a week with a resolution of symptoms, and allergens in the home is highly likely the dogs or an allergen at the home. A new environment. This is a new environment for the client that she had discussed, and postnasal drip and pharyngeal pain with erythematous cobblestone appearance are consistent features contributing to the pharynx pain of this diagnosis. The hoarseness of her voice can be contributing due to the ongoing irritation of the larynx with clearing her throat. So, and Mrs. S's fatigue is found to be due to the chronic lack of sleep. Due to her cough. A couple differential diagnoses is the upper airway cough due to asthma based on response to the treatment of the initial diagnosis. This could be seen to be if her allergies are impacting asthma symptoms, but at this time there's absolutely no indication of wheezing episodes, shortness of breath, or tightness in her chest, therefore less likely. And another differential diagnosis may be upper airway cough due to sinus infection. The mucus to her nose and pharynx was not purulent, and she's afebrile with no tenderness to sinus cavities. So it's less likely of a diagnosis. However, it could be of concern if it continues and if it develops into chronic sinusitis if symptoms are not controlled.